Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a documentary filmmaker and writer and a few other things, but I've been working with CCF for over 10 years, over a decade, creating countless videos. I need to add them all up, but I would definitely say hundreds if we're including video series like the one you're going to watch today, live video series. We've been in 2 seasons now, 2 years of Luncheon with the Experts or over that. Documentary based or patient centric stories, treatment based videos, conference videos, hundreds of videos, folks, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here today. Now, to do today, rather. Now, the program you're going to watch today, the value coming to you is twofold as far as I see it. One, the information that you're going to get from our guest presenters, our presenter rather, as well as the shared experiences and shared stories from the community. Now, this is something that I always like to reiterate every program. If you are new to the show or new to this journey, I want to say welcome. I'm glad you found us. And you see people chiming in on the comments saying hello and where they are signing on from around the world. Do the same thing. Reach out, introduce yourself. I promise you, this community is extremely supportive, and if you embrace them, they will embrace you back. And so that is a real big part of what we try to cultivate here on the show, is that community where sometimes, you'll learn just as much from them, from people sharing their experiences as the presenter. So make sure you reach out to people and tell us where you're signing on from as well. Before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, because simply without their support, we couldn't do the show. And we do have this disclaimer from them that we'd like to say at the top of the program, and that is that the opinions expressed today by the guest presenter, as well as the questions that you all at home have asked, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation today. So audience members, that's you, should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health and treatments. Okay, so that last line is really the takeaway there. We're going to give you some good general advice and answers to your question, but by no means do we, most likely our guest doesn't know your specific case. She might if you are her patient. But take that advice and those answers to your question back to your home team, which does, and make the best plan and path forward for you. Because if there's anything I've learned, even though I'm not a medical expert in the past 10 years of working with this disease, is each case is unique. Therefore, each plan and path forward is as well. Okay, folks, today I'm very excited to welcome back to the show for, I think, maybe a third time. I don't know. You know, on Saturday Night Live, the Fifth Timers Club, they get like a jacket. We may have to do something similar for Lunch with the Experts. Dr. Mary Maluccio, welcome back to the show.
Thank you very much. I do feel, does that mean I'm like a bad penny?
No. A lucky penny, I would say. So for those who maybe didn't see your first couple of appearances on the show, tell us a little bit about yourself and really the role that you fill in this neuroendocrine tumor community that we've already mentioned.
Okay, great. Thanks, Rain. So I am Mary Maluccio, and I run the neuroendocrine program in New Orleans. And I came and took over this program around 3 years ago with the retirement of the icon of neuroendocrine, Eugene Woltering. So definitely big shoes to fill.
Definitely.
And so I think what drew me to this part of the country is that I am particularly interested in sort of marginalized or disenfranchised patient groups, and rare cancer patients like neuroendocrine fall into that category. And so the opportunity to take over such a large program with the potential to have enormous influence in a part of the country that does not have a lot of subspecialty centers was just really kind of right up my alley. But the reason why I'm just so appreciative of you giving us this opportunity is that there's just really been a lot of change within the programmatic infrastructure, within our partnerships, but that I really want to get across to people that we still remain the neuroendocrine program, sort of the goal for the Gulf South. We love our partners, John Strasberg at Moffitt. We get along great with MD Anderson, but for most patients within the Arkansas, Oklahoma, Louisiana, Mississippi, Alabama, I want to be able to influence their care And I think over the pandemic, I just learned a lot of lessons about how a strong network of professional partnerships can help keep a lot of the care closer to home. And then we really don't pull people as much over state lines. And so I think that the great things are happening. With change comes opportunity, but that I didn't want anyone thinking that really we are any different in our mission or our vision, which is to just have more influence over neuroendocrine patients.
Absolutely. And if I could add to that list of states that you listed off, or Frank more specifically says, hello from Texas, to be included. Excited about the session. Love Dr. Maluccio. Thank you for all that you do. So Frank, I'm excited as well. You said something, Dr. Maluccio, that made me realize that, over the past 10 years or 12 years now, I think that I've been working with CCF, because when you mentioned Dr. Woltering, the first series I did for CCF, 2011 or 12, I featured him. And so I was, and Dr. Warner, Dr. Wolin, like all these titans that I was introduced to very early. Now I can look back and see how monumental they were. But I've also seen this transition to like this, I don't know what to call it, the next generation. I don't know, but like there's a lot of other specialists now. And that's part of what we try to do here on the show, is feature new people, new specialists in the space. But I think that it's really growing, and I'm so impressed by all the progress that we've had in the past 10 years. And I know a lot of that is owed to those OG titans that have been putting in the work for decades. But yeah, it's a privilege to have worked with them for sure. All right, folks, here's how we're going to do the show today. Go ahead and start sending in your questions. I want to give you a little bit of housekeeping before we get started. Really, I want to help you. And if you're a regular to the show, you already know this, but I want to help you get your questions answered. That's what we're here to do. The best way that you can do that is formulate your questions for me in a very simple way. So sometimes people think that the more information I give Rain or our guest, the better. It's not necessarily true, because when I'm looking through the comments, if I see, 4 paragraphs of all this very case specific information, I can't get to it. And we really can't get to it. Especially because most likely Dr. Maluccio is not your doctor and might not know your specific case. And that makes it really tough. What's going to make it easy is asking and formulating your questions in generic terms, and one question at a time. I know you're going to have follow-up questions. So start off with what's, is pressing, and then keep chiming in. You can ask questions as long as the program goes on. And if you see a question that someone has asked in the comment section that you also have, or you're interested in the answer to, one thing that you can do is just under the question, you can like it, love it, any of the motions that Facebook allows you to use. And what that does for me is effectively upvotes that question. If I see 8 people have that question, I know there's going to be a serious demand for it. So I'm going to make sure to get it across. We won't get to all the questions because we get a lot. Folks are already over 100 in the room, and that usually happens closer to halfway through the program. So there's going to be a lot of questions. If you have follow-up questions, reach out to CCF. Tune in next week. Don't get frustrated if you don't get your question answered. Follow up. That's what we're here to do, is to get those questions answered. But, in that regard, we're going to go ahead and start taking questions now. So go ahead and send them in. And if you do have a follow-up question that is related to previous questions you've asked, just give me a little context so that I remember, because I see so many. And so you could say, this is in reference to the previous question about ... and then answer your follow-up, or ask rather your follow-up question. That just helps me do my job a little bit better, which is, of course, to serve you. Let's get going with the questions from Lynn, our friend Lynn, who I see often. She says, PNETs with metastases to liver, started on and still on lanreotide, had PRRT, on CAPTEM or CAPTEM now, 2 years after the PRRT. Can a person feel the tumors growing or shrinking? Does CAPTEM cause any feelings or sensations in the abdomen?
Okay, well, that's definitely a patient-specific question. So I would say that the roundabout answer is that it probably depends. I think the likelihood that someone can truly feel what is usually a marginal increase or decrease in size on whatever therapy that we're using. But on the flip side, I've had patients after PRRT, especially with bone mets, say that they absolutely almost feel like they like almost feel that the therapy went there, and then the nagging pain that they would have just sort of went away, after the dose was delivered. so I would never want to say that what someone's feeling is not going to be related to some, changes at that tissue level. The unique thing about the pancreas is it is sitting literally in your back. It is sitting right in front of your vertebral body, and things cannot grow and have things shift to accommodate it. So even small increases or decreases can cause symptoms related to mass effect. And so therefore, if someone's feeling something, it could very well be because something's happening in such a tight space that even a marginal change would be able to not have it pressing so firmly onto those structures, especially when it comes to pain in that area. You've got neurovascular bundles back there that are going to be really sensitive to something pressing in that area.
Got it. Thanks, Lynn. Appreciate your question. Good to see your name. Let me know if you have another one. And this is this next question from Joyce is a good kind of question to lay down some foundation about this disease for those. So the question is, what is the difference between carcinoid syndrome and what might be considered carcinoid cancer?
Okay, so I think that there are people that really don't even really like even the word carcinoid,
right? Because
it's almost like it's like cancer light or somehow not really a cancer. And then I think that's where when people don't live in the world of neuroendocrine, even medical professionals, they tend to then go down this rabbit hole of something being quite, benign. And then they were like, oh my God, they told me it was benign. So, but all the same, the fact is that so many of the verbiage that we use, literally, you can't get around the word carcinoid because the syndrome is called carcinoid syndrome.
Right.
I think a lot of us have switched to saying neuroendocrine syndrome, but the answer to the question is actually pretty simple. So when we have a low grade, well differentiated, acting a lot like those normal cells, but unregulated, and it's in the mid gut and therefore likely to be a serotonin producing tumor, we use the word carcinoid. But that's because those are the people that are more likely to have symptoms related to elevations in serotonin levels, whereby that's what drives carcinoid syndrome, and then ultimately what can drive carcinoid heart disease. So we can't get outside of using that term. But the syndrome is not just about serotonin. So to say that something is carcinoid syndrome when it's a pancreatic neuroendocrine that is secreting something that is not yet identified or we don't have a marker for, we don't say that those people don't have the syndrome. It's just not actually an appropriate term to call it a carcinoid syndrome, right? So we tend to use neuroendocrine syndrome for all of so in other cancers, we call them paraneoplastic, meaning those things that are associated with the tumor or the abnormal regulation of the tumor, but that give you all over body sensations. And that's sort of the flushing, lightheadedness, dizziness, palpitations, cramping, abdominal pain, diarrhea that is typical for carcinoid syndrome, but that the term syndrome is the symptoms that are associated with whatever is being released inappropriately. And the carcinoid tumor is usually a mid-gut neuroendocrine tumor that secretes serotonin, where we use that term. But the fact is that we use that term in rectal carcinoids, and they rarely do serotonin. So the carcinoid tumor is the primary tumor. The syndrome is the symptoms that you get from overproduction of whatever it is that's driving those symptoms.
Perfect. Thank you. And thanks for your question, Joyce. Folks, if you joined us a little bit later or just joining us, this is Luncheon with the Experts at Carcinoid Cancer Foundation program. Today, we're here with Dr. Mary Maluccio, and the numbers continue to rise at a great rate today. So I think that a lot of people are anticipating this show, as am I. Also want to send a special shout out to our international friends, lots of people in the audience. Haim from Israel, which I think it's the first time I've seen your name. So if this is your first time at the show, welcome. David from Australia, Ajay rather from Nepal, lots of people around the world, and we love to see that. Next question from Jim. I get this question pretty frequently, I think. Are there any advancements or developments that you can share with regards to new treatment options being explored for patients without somatostatin receptors?
Yeah, that's actually a great question, because if you were to talk about, I wouldn't even say the word easy, straightforward. So if someone fits into a somatostatin receptor avid, primary or metastatic, we just all feel a lot more comfortable that the standards of care that we currently have are all appropriate things to put on a menu. But you will get into a group of patients that are either mixed grade or mixed somatostatin receptor avidity or not somatostatin receptor avid, whereby the tried and trues that we're so accustomed to throwing out there, we're not only less confident, we really start to lose confidence that those strategies are gonna work. So I personally think that the answer is yes. I think it is in the clinical trial realm, and that for the most part, we will be trying to test those tumors. So when I use the word genetic testing, that's when we test a person for genetic mutations that they inherited that are putting them at risk for whatever's going on in their life. Genomic testing, which is really just genetic testing of a tumor, is when we're doing the exact same thing, because once we were able to sequence the entire genome, we're now able to, and it sounds so much more complicated than it is, we're able to then take that tissue, stick it into a machine, and look for mutations that are potentially driving whatever it is that's making that tumor, I don't know, look or behave differently. But most, if not all, of the advances in that arena are going to be in what I call the systemic, the all over body treatments, which come under the umbrella of chemotherapy, even though you have to understand that chemotherapy is usually when we're trying to poison the whole body in order to poison cancer cells more, but that there's immune therapy that is trying to modulate your immune system's response to things that are foreign. And there's also targeted therapies that are looking at a different type of receptor mechanism than we're used to talking about in neuroendocrine, which is the somatostatin receptor that drives that avidity. We're trying to look at other receptor signaling that would be more appropriate. So for that question, one, I think that the national meetings and or some of these regional patient meetings are the ones that are going to be most relevant to that, because that's when all of us are talking about what's coming down the pike and how we would use our collaborative relationships in order to identify people most appropriate, for those things, and then how those things are integrating. Because when you say genomic testing, it should say, well, we usually will be, it's a one-offer, right. But that if we're going to all say, well, no, for things that are like not somatostatin receptor avid, and therefore we're losing confidence that we're going to take the yellow brick road that we're accustomed to. No, I think that those are the ones where there's a lot of collaborative interest in trying to figure out how we would quickly try to identify those patients and change the paradigm, because those are actually you're getting into the marginalized of the already marginalized, because they don't fall into something we're super comfortable, and therefore the decisions come easy. So I hope that answered the question, because I don't have specifics for it, but my answer would be yes. And our national meetings really address that.
Got it. Thank you. Thanks, Jim. Next question from Carrie and a few other people. Please explain the risks to surgical procedures to manage or remove liver mets.
Okay, so I think that a lot of that risk, not to say that there is no risk or limited risk to ever chiseling away at the liver, but I do believe that the risks, especially when you're talking about risks of taking out metastatic disease, are much into the experience and or the perception of the surgeon. So those of us that live in the world, I grew up professionally in the world of liver surgery. What I consider not risky, someone else would be like, that just is above my comfort level. So the liver is like a tree. It forms in fetal life from 8 different things, like floating around in the universe, all with its own blood supply. And then miraculously, it all merges together, but maintains that 3-dimensional architecture. So liver-directed therapies like embolization or ablative techniques or surgery are all taking advantage of the fact that a lot of that is pretty predictable. So what we're willing to do when something is deep within that 3-dimensional structure is going to come with significantly more risk. Things that are associated with the bile duct, meaning close to where we see the bile duct, that's the thing that drains the bile from your liver into your intestine. Well, the bile duct is the trickiest thing. And so a lot of the complications are not anticipating the bile duct, but that's because the artery has a pounding pulse, so it's easy to find. The vein is like as big as my finger, and as big and blue, so it's easy to find. but the bile duct is something that's less than the size of a pencil. It's super duper squishy. And unless we're looking at it in its predictable location, of which it is in a predictable location, the risks go up. So when I talk about or give advice to people, even over the virtual platform, when it comes to consider surgery versus not consider surgery because of the risk of the liver, that is when you should get a second opinion from people that may be a lot more either aggressive, assertive, or comfortable with those techniques. And if we say that the risk is too great and we choose this other thing, you know that you've heard it from people that feel really comfortable in the liver.
Got it. Thank you, Carrie. From Fred, what are some of the main symptoms of a lung net, and are there any alternate ways of diagnosing a lung net other than surgical biopsy? Also, is it possible to live with a very slow growing lung net without undergoing any treatment at all?
Okay, so the answer to that, I think all of those questions is yes. And so bronchopulmonary neuroendocrine tumors, of which we will also often use bronchopulmonary carcinoid, those can be. So when I'm giving this talk at meetings, that can be a thing the size of a rock that looks very much like a lung cancer versus something that is sitting within your airway that you can only see on bronchoscopy. So even that diagnosis is a whole spectrum of what it can be. But if you were to talk about what I believe he is addressing is that typical carcinoids, they come in two varieties, typical bronchopulmonary versus atypical. And that has a lot to do with the predictive of biologic behavior, the risk of metastases to lymph nodes and or distant sites. So if someone has a typical bronchopulmonary carcinoid, the symptoms actually are usually very much like asthma. So people will complain of cough, shortness of breath, air hunger, just a lot of chest discomfort that's very similar to asthma. But that's because the neuroendocrine cells of the lungs are all about getting stuff out of your lungs. So when you got too much being secreted, you get this sensation like you're always trying to push things out of your lung unnecessarily. But the typical bronchopulmonary neuroendocrine tumors are really actually have a low likelihood of driving someone's mortality. So the answer, should you live with a slow growing bronchopulmonary neuroendocrine without having it resected? Well, absolutely, because we follow many patients that will have multifocal bronchopulmonary neuroendocrine that we follow expectantly and may or may not even consider somatostatin receptor inhibitor therapy. So that's just a really, once again, a patient-specific question, but that I would be reassuring them that the answer is yes. The biopsies can be done percutaneously if it's big enough. They can be done endobronchial, but oftentimes it is that we end up removing it for both diagnosis and definitive treatment, but that we don't do that if we have suspicion of another one over the course of the remaining lifetime. We just assume it's going to be, a identical twin of the one that was removed.
Got it. Thank you. And actually another lung net question, and you and I talked about this before we started the show today. Alice or Elise says, do you have a lung specialist in your group? I had a lung primary, now diagnosed with dip neck, and I was a patient of Dr. Ramirez, formerly with your group.
Right. So the answer to that question is sort of. So I always use this platform to reassure people that faculty within neuroendocrine all get along really well, and we're super collaborative. So it's really not a competitive environment at all. So it was hard. It was a little bit heartbreaking when Rob Ramirez left our group. But at the end of the day, it was a great job for him personally and professionally. So we just had to say, go do. He remains, I think, a really important extended family member. And for people in particular with dip neck, it is not uncommon that I would reach out to Rob Ramirez. And unless he says differently, he very kindly, I think, kept his Louisiana licensure so he could see some of our patients over the virtual platform, knowing that we would be able to deliver whatever care was necessary with understanding the complexities of that unique case. Now, all the same, bronchopulmonary neuroendocrine tumors are often treated or watched in combination with pulmonary, and all of that infrastructure actually does remain. So I did take on a lot of those bronchopulmonary neuroendocrine, tumors, and for the most part, it is a relatively straightforward medical decision-making process. But the DIPNEC it makes it a lot more complicated, and therefore, it's not that we don't have that. It's just that we are usually calling Rob Ramirez.
And folks, speaking of Dr. Ramirez, who's definitely a friend of the show, he will be back on the show, I think, in early October, which he may have to get his third timer's jacket as well. I'm pretty sure that'll be his third time. But yeah, he's awesome. He's in Vandy now, but he'll be back on the show. And we also have a lung nets video that we created a couple of years ago that he was featured in as well. That's something I always want to reiterate and encourage you all to do, is we have a database. All those videos I mentioned at the beginning of the program, I've created with CCF for 10 years. They're free for you. That's a great resource, a library for you to tap into. You can go to YouTube, or you can just go to the videos tab here on our Facebook page. There is a video almost on every topic around this disease. I know we get a lot of questions. It seems like we've had more questions recently about lung nets. So I know there's a demand for that, folks. So that's a couple of things just to give you an announcement. And we're going to stay in that same vein because Jennifer has one as well. And her question is, if a person had IBS-like symptoms and recently found a lung net, which has now been removed and scans are clean post-surgery, would you assume that the IBS-like symptoms would be NETs?
Yeah, so I think the short answer, once again, without understanding more of it, a short answer, I feel comfortable saying no. One is that bronchopulmonary NET usually presents with respiratory symptoms and not the typical symptoms. Now, bronchopulmonary NET that secretes some of the unusual things like ACTH can have some of the most profound paraneoplastic type syndromes of any neuroendocrine that we see. But that the sort of crampy abdominal pain, diarrhea, food insensitivities, and things like that are typically leading to delays in diagnosis of midgut NETs because they get categorized as irritable bowel or inflammatory bowel disease, are really not as common in neuroendocrine. So if you have something where you say you had a typical bronchopulmonary NET, completely excised, negative margins, and your cross-sectional imaging and or PET imaging is negative, I'd be hard pressed. I'd be telling the gastroenterologist or the primary care physician, because they're so quick to say, oh, maybe this is NET. I'd usually say, no, don't either deny someone or delay the evaluation and management of a non-neuroendocrine condition, because those are actually more common than neuroendocrine. But that we do remain a lifeline for those people to say, hey, I just want to let you know, I do not believe. I'm willing to absolutely evaluate it, but that we need to just agree that it's unlikely to be neuroendocrine related. And therefore, if you feel like someone needs further evaluation, I would be going down that road.
Got it. Thanks, Jennifer. Hope that helped. And let me know if you have another question. From Jim, please explain SUV. What is it? What does it tell the doc? Is there a range, high, low, normal?
Yeah, so that's also, I actually really like explaining SUVs to patients, because I think they're so used to looking at cross-sectional imaging like an MRI or a CT scan, and they're looking at something that is a certain size in a certain location, and they're saying, okay, if it grows, that's bad. If it shrinks, that's good. It's like cancer for dummies. But the PET scan is an incredibly valuable tool. So when we talk about somatostatin receptor density, so how I describe that so that people can understand it is that receptor, I call it a parking space. So that receptor is sitting on that cell, and the activity or the avidity or the hotness of that is going to be that SUV value. So the real term is somatostatin receptor density, meaning how many receptors do you have on that cell. So how I describe the PET scan is like injecting with a little car with pizza delivery light on top of it that's driving all over trying to find a parking space receptor on those cells, and it's sending out a signal. So the higher the signal, the higher the SUV, the more cars you have parked on that cell. So, but I don't want people to say, oh, if this SUV goes up or the SUV down, is that good or bad? Well, that is very difficult to interpret. So you can't get hung up on the SUVs. Now, if you're getting PRRT, and that is like a little car with a radiation particle on top of it, and it's trying to find those same receptors, well, yeah, it does mean something, because the likelihood that you're going to have a disproportionate number of the drug or the PRRT go to a higher SUV cell would seem logical, even though that's not exactly testable, right? So an SUV, for example, can be higher from scan to scan if someone has a decline in renal function and the cars are circulating for a little bit longer. So I never want people to get hung up on the SUV, but I'm sort of interested in almost any piece of information that we're getting. And so I think that we tend to not actually address it because it doesn't change a lot of what we do, but the patients that are reading their reports are like, oh my God, it was only a 20 before and now it's a 40, or it was a 40 before and now it's a 20, and wondering what that means. And so I feel like it's, for different treatment modalities, it does make sense. It just doesn't weigh in to this. But if I have an SUV of 60 in a liver metastasis and someone is syndromic, well, you better believe if I'm going to have an interventional radiologist shoot some bullets, it's shooting the bullets into the SUV of 61, because that's likely going to be the one driving a lot of those symptoms.
Got it. Thank you. Next question from Art. Hey, Art, is it the serotonin that causes the bowel changes in upper airway wheezing? How does the lanreotide block it?
Okay, so that's also a great question. So I believe that for the most part, we believe that a lot of those carcinoid related things are serotonin induced. Serotonin is what causes intestinal peristalsis, and so therefore it takes things from the top to the bottom faster. It's trying to get things out of the lungs, and so therefore you're going to have that sense of sort of asthma or cough. So I think that the short answer is yes. So trying to block signaling through that. So serotonin is just a natural thing all over your body. It gets triggered by certain natural triggers because it's a part of normal neuroendocrine physiology, but neuroendocrine patients are having trouble turning it off. So neuroendocrine is about turning something on and turning something off. But if you turn something on, it doesn't mean it'll never turn off, but you get this delay in turning it off, which is what then causes you to have these, symptoms. So if you're looking at lanreotide, the analogy that I use for that, which probably is just like, oh my God, medical oncologists like, why does she say that? But that I use that as a little car. I feel like I always have this car, and that's a car driving all over your body, trying to find the same parking space, which is the receptor by which serotonin binds and triggers that cell. And it's a car, and it's binding, and it's like a police officer putting a boot on the car is trying to cripple the cell and keep it from spewing out the stuff that gives people symptoms. But it also, as we know, does mess with the mechanisms by which it divides and is associated with a delay in growth of tumors. So that the somatostatin receptor inhibitor is a twofer, but that the way that it's blocking it is an analog. It's a competitive agonist, meaning that it's going to bind just like the serotonin would bind, but unfortunately it's blocking that parking space. So the natural serotonins that you cannot control all those triggers in your life. In particular, you can't control stress or emotional triggers of carcinoid syndrome. So since you can't control the triggers as well, we're just trying to control how those natural, triggers are actually being able to signal through those cells.
Got it. Thank you. From Anthony, with an MEN1 negative, should I still have my children tested?
Well, no. So you're the neuroendocrine prototype. We call it the prototype if you're the only one in the family that has it. If you're negative, your kids are negative. So that's why we test the prototype, because if the prototype is positive, that's what justifies our testing the siblings and or the children in that. And why I think that is really important, and a lot of us feel that we've under-recognized genetically driven neuroendocrine tumors, is because if the children are negative, you can really almost put it to rest in the next generations down. But if the children are positive, we do manage that children and their generations beyond that differently.
Understood. Thank you. Well, next question from Sheila. What symptoms are associated with teeny nets in the small bowel, and what types of tests may be used to help find them?
So when you say teeny, it's hard to know. So whether or not that is because someone has multifocal, so especially mid-gut neuroendocrine tumors can either be big enough to cause a bowel obstruction. They can be multifocal, like weeds along, a lawn, whereby removing all of it is highly unlikely. And so depending on what it is we're trying to find. So if something is multifocal, we are more likely to then use a PET scan. I call that the needle in a haystack scan. Use a PET scan to try to better understand extent of disease, and definitely to better understand someone's symptoms in the context of the disease. But a PET scan is only going to be sensitive enough. It has to be at least a certain size or have enough somatostatin receptor density to even be positive on the PET scan. So when people have multifocal within the small intestine, we do have the option, especially so post-surgical, we have the option of using a colonoscopy that can then get into the small intestine. We have specialists, so Danny Rains in our group, specialists in long scopes, meaning they literally inchworm your entire intestine over a scope to be able to better understand it. We have capsule endoscopies where you swallow a camera and it goes all the way through and takes pictures all the way through your intestine. So we have very sophisticated ways of looking at things if we believe that it's multifocal or teeny within the lumen of the intestine. If we're talking about whether or not it is teeny or someone came out of an operation and said you have small volume disease within the mesentery and things like that, that is very difficult, but that's super important to know that the surgeon found that at the time of exploration, because we do maybe interpret films a little bit differently. We may use different techniques, but I do think we will almost default to the PET scan to try to better understand whether any of those are becoming more clinically relevant.
Got it. Thank you. And thanks for your question, Sheila. From Samantha, are liver metastases clearly defined from scans, or is biopsy required if there are suspicion of carcinoid and multiple benign looking liver tumors?
Okay, so that's actually kind of a difficult question to answer, because so if someone has a neuroendocrine diagnosis and has abnormalities in the liver, the answer is that we have to raise or lower our suspicion, because you can have benign non-cancerous things in the liver. An MRI is usually what we will use. Now, if someone has a neuroendocrine diagnosis, has abnormalities in the liver, we will often get the PET scan first to see whether or not they're somatostatin receptor avid. But if you remember, the first question was that not all of them will be somatostatin receptor avid, so that doesn't rule in or out. There will be times we will biopsy something in the liver, because sometimes the primary tumor will have a different grade, and the way that we are making medical decisions is on the highest grade in a multi-site. So if you have a primary that's a certain Ki-67 versus a lymph node that's a certain Ki-67 versus a liver grade, well, we would take the highest grade. So if we think that that's necessary, we will biopsy it. But that if we're saying, oh, you had a one and done operation, most of what's looking in the liver looks like the benign things that we see in liver, like a cyst or an adenoma or whatever, then an MRI is the best way of distinguishing something that looks typical of the benign diagnoses that we're very familiar with versus with enough suspicion that it's neuroendocrine. And if you can't make a call, we biopsy.
Michael asks says, I believe that surgery is the only cure, but surgeons seem reluctant to operate on the liver. What's up with that?
Okay, so I think that's when I would caution people about using the word cure. So I do give a talk about how we use those terminologies. If an operation is done with curative intent, it is meant to eliminate this as a variable, as a driver of mortality over whatever remaining lifetime a patient has. So something done with palliative intent is obviously done because we're trying to alleviate a certain symptom. So then we have to identify the symptom: pain, flushing, diarrhea, bleeding, obstruction, whatever it is. And then you'll have the cytoreduction, the thing in the middle that is sort of the prolongation of life. And in removing as much disease as you can, you are then going to have an impact on either how well the additional treatment will work, or on the survival or symptoms over the person's remaining lifetime. You can't really use the word cure if someone has a secondary tumor in the liver, because that's metastatic, that's stage 4, but it does not mean people can't live a long time. And it doesn't actually mean that we can't remove all measurable disease, because that's actually going to be our goal. But that the word cure would not be used, but it does not mean it is not of value. It's just that we're trying to categorize it with realistic expectations of likelihood of having a neuroendocrine specific event over a remaining lifetime.
Got it. Thank you. I have an interesting question from Linda. Have you found any correlation to environment causing neuroendocrine tumors? With this being such a rare cancer, it's strange and ironic that my childhood neighbor contacted me last week, letting me know that she was just diagnosed. And so I've recommended a NET specialist. Great job, Linda. But yeah, any thoughts or anything that points to something in the environment?
Well, I think that epidemiologists, or the people that look at your environment and the risk of a number of medical conditions, including cancer, would likely have an opinion on how environment affects a lot of things that happen to us. So it is virtually impossible to say that environment does not have a role when we eat, drink, breathe, all this stuff, and neuroendocrine tumors are most often in those sites, right? So it's virtually impossible to say that it is. Well, unfortunately, if we all watched Aaron Brockovich, is that it's virtually impossible to link it with certainty to any particular environmental exposure. Whereas, like, we know that, Chernobyl level radiation leads to thyroid cancer, or we know that certain industries, whether or not that be the dry cleaning industry, Agent Orange, whatever, leads to bladder, like those types of things. And so those links have been established because those patients were getting these rare tumors where there's no other reason other than they all got Agent Orange. But to say that you and your neighbor were to get the same diagnosis, having grown up in the same area, well, it's all rare, right? And so, yeah, I'm sure there's an odds to that, maybe not like winning the lottery odds, but the odds of that are low. So to say that it's not associated with an environment, it would just be likely inaccurate, although I have no way of pinning it on the power plant down the block or your water.
And Linda, this on the flip side of that, this is not exactly the same case, but we have an interesting story we told in 2018 about two best friends, Ellen, who sometimes is watching on the show, and our dear friend Sochi, who were best friends, and they got the same. They didn't grow up together, but they were best friends. Later in life, they met and got and both got neuroendocrine tumors. So sometimes it's just an odds thing that can happen, but in your situation, that would be a little bit different potentially, since you grew up together. But I just wanted to make mention of that because it's such a great story. And if you go back and look at our 2018 series, we did 12 patient-centric stories that year, and they're all very, very heartwarming, great human stories. And to that point, we actually just released our first out of a 5-part series this year, 2 days ago. So not right now, we got 15 minutes of the show left, but afterwards, if you haven't seen it, I want to encourage you to go watch Eileen Bildman's story. It's called Life in the Fast Lane. It's on the top of our Facebook page. But listen, at age, I think 58, she has a neuroendocrine tumor patient. She became a Ferrari race car driver. It's an amazing story. Go check it out. And do me a favor. If you do, please share it with anybody else that you think needs to hear it. Okay. Next question. Oh, this is a lot of people liked this. So there's a demand for this. This is an interesting one. Can Dr. Maluccio, this is from Penny, can Dr. Maluccio talk about her work with patients and a keto diet or a ketogenic diet?
Yeah, it's Penny's fine, my patient. And I'm sort of a nutrition nut. So, because you have so many food triggers, that it's a little bit hard to know how you are what you eat, even though that whole cliche, we are what we eat.
Right.
So a keto diet is considered a more of an anti-cancer diet or an antioxidant diet, because it's trying to eliminate those things that are exposing us to antibodies that are in our cow milk or our meat or our eggs or things like that. So the reason why a keto diet is healthier is because it is eliminating those types of things. But it doesn't mean that eating a non-keto diet is necessarily unhealthy. The reason why I bring this up with my patients is that patients, especially people that are advocates enough to like plug in on this, is that if you're trying to control certain aspects of your life, like you're saying, I want to be able to take more control, we do have ways that we can control, as long as it doesn't like ruin the quality of your life. So people are like, oh my God, she's going to bring up her smoothies. Well, you can get so much fruit and vegetables, which is exactly what has been studied. Americans do not eat enough fruits and vegetables, but I am guilty, man. I'm not going to be like stirring up fruits and vegetables in a pan, like 8 servings of fruits and vegetables. Like, you freaking kidding me? It's not going to happen. Whereas if you just invest in a Ninja Bullet and you dump it all in, and I tell people that even some of the commercial smoothie makers, they're putting those supplements in. Those aren't like, they aren't like sticking like 18 pieces of broccoli and kale in your thing. No, there's and the reason I know that is because if you do that, it turns the whole smoothie brown and no one is going to drink that. So they use additives like Amazing Greens or organic greens or things like that. And you can do that. So the reason why this has come up in some patients is because people, neuroendocrine patients, even though intermittent fasting is also an incredibly healthy way to eat, they do not tolerate. So neuroendocrine patients do not tolerate intermittent fasting. They also don't tolerate the large 3 meals a day. So then you have to go for the multiple meals, which is not exactly convenient. So I just put it all in a thermos and say, hey, why don't you, because that's sort of the keto way, is that you would just have it all in a thermos. And then really whatever you do between that doesn't have as much effect, or you can just do your own experiment. But that I am not by any means saying all neuroendocrine patients have to go on a keto diet, but I'm going to confess that I will go over dietary and behavior modification with a lot of patients, especially patients that go on the somatostatin receptor analogs.
Well, I think a lot of people are interested in that too. So I appreciate you chiming in on that. From Shane, do you think metformin enhances SSA therapy?
Well, I think a lot of us in neuroendocrine would prefer to use other. I mean, there's so many other agents in the oral hypoglycemic area. The major side effect of metformin is diarrhea, and so when people have diarrhea as any component of their thing, or if we're trying to understand whether or not someone is having more or less symptoms of their neuroendocrine tumor, metformin makes that a lot more complicated. But whether or not metformin has any effect on how an SSA functions, whether or not it raises or lowers effectiveness, I would have to say that I'd have to see the article before I believe that we have studied that to that extent. And for the most part, I would say most of those first generation oral hypoglycemics have a very common mechanism. And it's not until you get into the Trilicities or the Ozempics where you're really altering things to a significant effect, where we would have to study how that affects another metabolic type drug like SSRIs.
Got it. Thank you. From Shelley, what is the standard interval of PET gallium or copper testing suggested for NET patients with liver metastases?
Yeah, so that's going to be a patient by patient say. So that is actually not written in any guidelines. How we use PET scans is going to be based on individual features. The way that I describe it is that I say there are a handful of reasons we would consider updating the somatostatin receptor PET imaging. New or worsening symptoms suggestive of the evolution of a neuroendocrine syndrome, changes in blood work that would suggest serologic progression of disease, or changes on conventional cross-sectional imaging that would suggest we needed to update the extent of disease evaluation. But when people have multi-organ site involvement, if you have liver, bone, lymph nodes, or you have multifocality or anything like that, well, I have a much lower threshold for saying, hey, maybe we need to get updated PET imaging. And then obviously we need that PET imaging before we consider something like PRRT.
Got it. Thank you. We have this question is a good general question that we often get, and I think it's still kind of under debate, but the question is from Jeffrey: if serotonin is the feel-good hormone in the brain that we're mostly familiar with, and you are taking somatostatin injections that block serotonin, how does that affect the mental state at all?
Yeah, and that is such a great question, because it is something that does come up, and I think because we don't overlap with like neuropsychiatrists, even medical professionals, it's like it's our own ignorance in how that works. So if I understand it correctly, because I have people that are on SSRIs and obviously serotonin reuptake inhibitors that acts on your brain, and they will have then really low plasma serum serotonin levels. And I'm like, is that because my drug is driving it down, making things worse? And the neuropsychiatrists reassure me that the answer is likely no, that how we're measuring it in the blood is and the effects on systemic levels of serotonin are very different than how we are measuring it and or treating it in the brain. So mood disturbances and the happy serotonin is all about serotonin levels as a neurotransmitter in your brain, and that there's not an absolute correlation between higher or lower elevations. And because a lot of people are like, if my serotonin is like 800, why aren't I like the happiest person on earth?
Right.
And that's because if we measure it in your brain, it's likely not 800. And those two, they're just not connected, even though I have had neuropsychiatrists tell me that it's not that they are not at all connected. It's just that not in the ways that this person or me understand how those things work.
Yeah, I hear even outside of this space, a lot of debate about that topic. So I'm always interested in talking about it. By the way, Dr. Manchoan has chimed in and said, hello, Dr. Maluccio and Rain. So always want to send him some love. From RM, has there been any study on increased incidence of NETs or NEC among burn pit veterans?
Yeah, so that actually comes up to, so we go back to the environmental exposures and whether or not we could truly say that there is or is not a link. If you were to look at some of that, and I know that it's been extraordinarily controversial and politically charged in the recent, probably past like the last 2 or 3 months. If you were to think about exposures that are environmental exposures that either go through your skin or the lungs. I'm like brain fart. So lungs is that usually those are actually more associated with other respiratory conditions. Like I would have said lung cancer and stuff like that. Absolutely, because you get such high concentrations of those toxins within a fixed area that has the inability to actually get it out. So things that are generally through your skin can cause things that are usually going to be within your urinary tract because you're trying to get it out. That's why there are higher incidence of things like bladder cancer, urinary tract cancers. There are a lot of things that say, well, maybe part of that is going to be driving some of the pancreatic cancers that we see. But that I wouldn't say that we have enough data to say that causes such a heterogeneous, neuroendocrine is just too heterogeneous. But that if someone said, well, 8 people in their battalion all got abnormalities within their neuroendocrine system in their lungs, I would be like, well, how can you not say that 8 people that were all exposed to the same thing, it's not somehow related? I would say that usually if you were to look at like the 9/11s, the burn pits, things like that, it's usually going to be a high incidence of other respiratory conditions that can also kill you. And that I think the data is just stronger in those things. And it's just weak in neuroendocrine. Doesn't mean it's not linked. It's just that we'd have trouble proving it.
Got it. Thank you for your question. Next one from Elaine. Primary small bowel NET with liver metastases 4 years ago. Primary NET has been removed. Sandostatin and everolimus treatment, keeping tumors at slow growth pace, but still growing. The question is, at what point should I consider PRRT And do I have to stop sandostatin before PRRT?
Okay, why don't I answer the second question first? Because
Okay.
the answer is yes, we stop sandostatin or somatostatin receptor inhibitor 28 days before PRT because they're competing for the same parking space.
Gotcha.
The answer to the other question is that I believe that you really have to understand all of the treatment options and why we would or would not take advantage of those treatment options in any given case. So for someone with liver only and or liver dominant disease, to leave out liver-directed therapies would be leaving out what we've done for this disease for over 40 years. And then jumping to PRRT, which I absolutely appreciate, has been used in Europe for probably 15 or 20 years, but is a little bit newer integrating into treatment paradigms in the US. So the way that I go over this with patients, even at diagnosis, is that I put the whole menu out there, like you're going to a Chinese food restaurant, you put the whole menu out there. And then you have to say, well, surgery for the primary, I think that there's very little controversy in that. It can cause symptoms. And then we're doing the emergence and surgery under more dire circumstances. So, and then surgery for the primary and the liver, very patient specific. We'd have to meet certain goals. So I can understand why we don't do that right off the bat. But it doesn't even take surgery off the menu. So to say that you say, oh, when would I consider PRRT? They've obviously, for whatever reason, chosen chemotherapy with the Afinitor.
Mm-hmm.
So there are probably features of the case that are driving those medical decisions. But that once you're going back and saying, okay, now we've reached a fork in the road, you kind of have to go back to all of the options and say, okay, surgery, yes, no, what reason? Liver-directed therapies, yes, no, what reason? PRRT, yes, no, what reason? And I can tell you examples where if you have, limited larger tumors, liver-directed therapies has an excellent effectiveness, meaning the objective response rate is greater than PRRT. If you have miliary, really small volume disease in the liver that's somatostatin receptor avid, well, the way that you can distribute therapy over, 50 tumors, 100 tumors, well, PRRT is going to win. They're going to win in that medical decision making. And surgery, obviously, for taking time to live, that doesn't make sense. So that's where I feel like when I go to conferences, patients just don't get enough explanation about why they are or are not in one category. It's almost like they get put on a road, and that road could make total sense, but that their interpretation is that it's one road, like one highway, and that's the only highway, and everything is just going to be towards not having any treatment options. And I just feel like that's not the way that many of us approach neuroendocrine.
Right. Are there any studies going on now that are exciting to you that you're hopeful for?
Oh, well, sure. Well, and if Aman Chauhan still on, is one of my reasons for sort of changing direction of our program in the South had a lot to do with our ability to bring novel therapies, clinical trials, or whatever, to a part of the country that is often, not included in a lot of those multi-institutional stuff. And so I'm really super optimistic about the clinical trials that are coming down, including some of the clinical trials that are at the Markey Cancer Center in Kentucky, and likely clinical trials that are also at Moffitt Cancer Center under John Strasberg or at MD Anderson under Dan Halpern. So that I think there are. So am I particularly excited about the PB212? That's the radioactive lead for people that are considering PRRT. I really am. But what I think people don't understand is it is still, in trial. So we can't say, oh, it's better than lutetium. No, we can't. But the fact is, the phase 1 data, the initial data was actually really quite promising. I think a lot of us are excited about that for PRRT patients. Some of the somatostatin receptor analogs, like Aman Chauhan has the oral somatostatin receptor analog. Oh my God, is that not a game changer for people? But I look at that as someone that deals with a lot of medical deserts within the South, a lot of rural patient populations, the idea of being leashed to an infusion center every month. Some of the things that are really ultimately, if those pan out, those are going to change like the day-to-day life for people that live a really long time. So there are other things, looking at other depot injections that patients would be able to be treated. To give to themselves. I think that's going to lower the overall cost of that month-to-month a treatment. I think that some of the radioisotope stuff that is really coming to fruition in Europe will likely get through into the US a little bit faster. And then if you were to go to Aman's portfolio, where I'm just like, OMG, some of the things like the guy that asked about the higher grade tumors and some of the chemotherapy combinations, I think actually almost everything's moving at a much faster pace. And I almost think that almost every clinical trial that's in neuroendocrine is, unlike other disease processes where there are like 8 things up until that point before you're even considering it. Now you've got the menu is really getting much larger. And so I really encourage patients to kind of look into those types of things, ask their primary neuroendocrine person about them, and inquire about how they may be eligible for those types of things. But that, once again, I go back to the fact that we get along all really well. And so if one person's got an awesome trial, it's like all of us do. And then it's just the complexity of getting our patients there.
Absolutely. Well, folks, that is our show for today. Belinda says, phenomenal luncheon with the experts today. Many thanks. We appreciate that, Belinda. I agree. Folks, before we go, I just want to say a major shout out to Grace Goldstein. This is her last luncheon with the experts, where she is behind the scenes, the engine, adding all the links and all that, who has been with the foundation for 19 years. She is retiring on the 31st and has been a mentor of mine for over 10 of those 19 years. And I appreciate her so much and I'm grateful for her. And I know you are too. So make sure to send her some love. But we wanted to say thanks for everything for here on the show, who she helped create this. And Dr. Maluccio, thank you for being back again. The people have spoken. We'll send you some of the comments tomorrow, but everybody's very appreciative, as am I.
Yeah, and if I could make a couple shout outs too of the people that we lost over the course of the last year. Please. Tom Odorisio,
big
the
time
icon. I mean, he, like Gene Woltering, they've spent their entire professional lives advocating for patients with neuroendocrine and built just phenomenal programs at a time when they were trying to change the world of the entire country. And then what people may or may not know, so I hope that Paris Manicunian won't be mad at me, but we lost the icon of the Manicunian who runs the ISI lab in Southern California, who along with Gene Woltering and Tom Odorisio, literally spent his entire life trying to better understand some of the metabolic derangements in patients with neuroendocrine. They wrote an entire book on it. We lost him over the past year. But at the same time, I do, just like you said, it's not even the next generations. I feel like I'm just channeling a somewhat younger version and different gender of Gene Woltering at this time. But that Paris Manicunian, I mean, they are just almost taking on the torch of their of their mentors, and just continuing to push the neuroendocrine programs further. So I just want to make 2 shout outs for the people.
Absolutely. And I appreciate that. And thank you for being with us today and sharing your experience and knowledge. And thanks to you all, you folks at home. As always, we hope this program helped answer some of your questions. And I'll reiterate one more time, you can watch the show as soon as it's done. It'll be on YouTube next week for those who don't have Facebook. And you can always reach out to CCF either here on the Facebook page or at carcinoid.org. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye now.
Bye.